Please be seated. So welcome to the second day of Family Medicine Forum. My name is Francine Lemire. I'm a family physician and Executive Director and CEO of the College of Family Physicians of Canada, and it is my pleasure to host you this morning. Every year at Family Medicine Forum, I am reminded how special this opportunity is. Continuing professional development is a key element of FMF, but this forum is so much more. And to me, especially thinking about some of the sessions I went to yesterday, it really is about transforming lives. And I hope, in some cases, about supporting you as agents of change in your respective communities. Les membres de notre collège forment une communauté du savoir, de pratique et d'apprentissage bien unique. Nous créons, adaptons et diffusons des connaissances. Dans une certaine mesure, chacun de nous est transformé par notre expérience au FMF. Let's preserve and nurture this feeling and the unique opportunities that we have to network and learn from each other. It is my pleasure this morning to introduce to you the members of our platform party. And I will introduce them and probably ask you to hold your applause until I've done this wave. So to my right, well, I don't know, somewhere in there, raise your hand. Madame Laurence Lévy, Scotiabank District Vice President, Montreal and East District. Dr. Ralph Massey, Chair of the CFPC's Research and Education Foundation. We are pleased to welcome today's keynote speaker, Dr. Danielle Martin, Vice President, Medical Affairs and Health System Solutions at the Women's College Hospital. Dr. Kathy Lawrence, CFPC President for another hour and a half, and Dr. Gary Mazzuita, CFPC's President-elect. We're also very pleased to welcome many of CFPC's national past presidents with us on stage to witness and welcome Dr. Gary Mazzuita, who will be installed this morning as the CFPC College President for 2014-2015. We will introduce our past presidents individually as part of that ceremony a little later in today's program. I'd also like to welcome some special guests in the audience. 3 members of the CFPC Executive Committee, Dr. Jennifer Hall, Dr. Claudette Chase, and Dr. David White, and a number of chapter presidents. Dr. Patricia Smith, President for Alberta, Dr. Paula Schwann, President for Saskatchewan, Dr. Susan Fair, President from Manitoba, Dr. Jonathan Kerr, President from Ontario, Dr. Dominique Deschênes, Présidente pour le Québec, Dr. Pierre-Paul Tellier, Chair, Family Medicine Forum Advisory Committee, Dr. Anna Patricia Prévost, Chair of the Scientific Program Committee, Dr. Rénal Bergeron, Doyen de la Faculté de Médecine de l'Université Laval, Dr. Cal Gutkin and his wife Mary, Mr. Hakim Ben Madi, Business Development Manager for Scotiabank. I'd ask those individuals, all of those whom I've named, to rise and be acknowledged. I would now like to invite Dr. Ralph Massey, Chair of the REF, to come forward and introduce this morning's keynote speaker.
Thank you, Dr. Lemire, and good morning, everyone. It is my pleasure to introduce Dr. Danielle Martin as the 2014 CFPC Scotiabank Lectureship Award recipient and today's keynote speaker. Dr. Martin is Vice President, Medical Affairs and Health System Solution at Women's College Hospital in Toronto, a family physician in the Family Practice Health Center there, and an assistant professor in the Department of Family and Community Medicine and Health Policy, and Management and Evaluation at the University of Toronto. An advocate for research and education in the areas of healthcare policy and healthcare systems, Dr. Martin believes that progress in both areas are required in order to meet community social needs, community health needs, and achieve social change. Helping people better understand the healthcare systems in Canada is key to making it better and going stronger forward. For more than 10 years, she has also advocated for the preservation and the improvement of the public health care system of our country.
Le leadership et l'expertise en politique de la santé du Dr Martin et sa passion pour l'équité sont reconnus tant sur la scène nationale qu'internationale. Elle participe régulièrement à des initiatives visant à promouvoir notre système de santé auprès des instances médicales, des décideurs et des gouvernements. Elle traite aussi de ces enjeux dans son travail universitaire et ses projets de recherche.
In 2006, she helped launch Canadian Doctors for Medicare and served as chair of its board until May 2013. In March 2014, she appeared at a U.S. Senate committee's investigation on healthcare systems, specifically focusing on single-payer and multi-payer systems and wait times. The CFPC Scotiabank Lectureship Award recognizes an outstanding Canadian or international figure who has contributed significantly to issues relating to the health and well-being of people in Canada and/or around the world. I'm sure you will agree that Dr. Martin is a most deserving recipient, and we're very pleased to have her with us today. Please join us in welcoming Dr. Danielle Martin to the podium to present her keynote address.
Good morning. Thank you. Thank you, Francine and Ralph, for your kind introduction. And thank you to Scotiabank and to the college for the tremendous honor of this award and the opportunity to share my thoughts with you this morning. C'est un honneur de pouvoir m'adresser à mes collègues ce matin et d'entamer avec vous une réflexion sur les moyens que nous, en tant que médecins de famille et Canadiens et Canadiennes, pouvons employer pour réaliser les promesses de l'assurance maladie du Canada. Among the many roles that we play as family doctors is the role of change agents at the level of the healthcare system. This involves moving from what the great Ian McWhinney called the territory, where we walk through the lumpy road of life with our patients, up to the level of the map, where system thinkers reside. While our role in the territory is profoundly important, there is magic in what can be done for the health of our communities if we get the map right. And it has always been my view that as physicians, we are uniquely positioned to drive system change for two major reasons. The first is that we understand evidence. We're not afraid of graphs and spreadsheets. Just as we can critically appraise the evidence on the relative merits of a PSA screening test, we can understand the data as to whether or not centralized intake works to reduce wait times. But that's not all. As frontline clinicians, family physicians see the human effects of healthcare policy on our patients every day. We understand why the promise of Medicare matters to real people. We can function as translators between the territory and the map. So this morning I want to take some time to reflect with you on the ways in which we as family physicians and as Canadians can live up to the great promise of the map of Canada's most cherished social program, Medicare. So to begin, I think it's probably important to articulate what exactly the promise of Medicare is. And it might seem obvious that that has something to do with living up to our values, and specifically the value of equity of access to healthcare services. Put simply, Canadians believe that access to healthcare should be based on need, not ability to pay. But Medicare binds us together in more ways than just delivering healthcare services. It strengthens our economy, it improves our social stability, and it gives us an example that we can point to of what our nation stands for. From coast to coast, as Canadian Doctors for Medicare have said, it is seen as the highest expression of Canadians caring for one another. So to me, that's the dual promise of Medicare: to deliver accessible, high-quality services in an equitable way, and to give us something to be proud of. Which means that when we think about improving Medicare, we need to think not only about improving the delivery of healthcare services, which is frankly hard enough, but also about what is needed to make a social program worthy of iconic status. Quand nous songeons à améliorer l'assurance maladie, nous devons penser non seulement à améliorer la prestation des services de soins, une tâche difficile en soi, mais aussi à ce qui est nécessaire pour rendre un programme social digne de statut d'icône. That's a high bar to set. But if we choose improvements that are grounded in our values and informed by the best available evidence, I believe we can meet it. So today I want to share with you 3 big ideas that I think can help us to fulfill that dual promise and reflect on how we as family physicians can help to advance them. But before we get to the big ideas, I want to just take a moment to take stock. I think we need to look at 3 critical dimensions of Medicare: cost, quality, and access, to point out some important realities that frame what it is we need to do. So first, cost. We spend a lot of money on healthcare in Canada, as do all developed nations. Last year, we spent 11.2% of our GDP on healthcare services, which puts us in line with other OECD nations, but in the top third. But unlike most of our comparator countries, the proportion of that spending that is public is actually near the bottom. For every dollar we spend on healthcare in Canada, 70 cents is public. In France, that number is 77. In Norway, it's 86. We spend a lot of money on private insurance and out-of-pocket services that are not covered by Medicare, such as prescription medications and dental care, and those numbers are increasing year over year. But look, what we spend may not matter so much if we're getting good value for money. And on many measures of health and healthcare quality, we do reasonably well. Canadians report very high levels of satisfaction with the quality of our healthcare, with 71% saying that the healthcare their families receive is good or very good. And our health outcomes in general do reinforce that perception. Our life expectancy of 81 years is a year ahead of the OECD average. Our infant mortality rates are lower than the average. And we rank 4th out of 16 peer countries in deaths due to circulatory disease, which, as you know, is the #1 cause of death in Canada. But while all this is terrific, there are areas where quality really needs to improve. This year, a Commonwealth Fund survey of 11 countries placed us second to last, both for overall health ranking as well as for primary care performance. One reason we rank so poorly, and this will be familiar to all of you, is lack of coordination. Too often, sick Canadians cycle in and out of hospitals and emergency departments, receiving treatment from different providers who don't talk to one another. And nearly half of sicker Canadians report that their most recent visit to an emergency department could have been at their usual place of care instead, had it been available. Food for thought for us as primary care providers. But of course, the controversy about Medicare in Canada has nothing to do, or very little to do, with quality. It's about access. Our system does a terrific job of delivering when people are seriously ill, and I think that most of us are prepared to accept some amount of waiting in a system where we know that everyone has access. But as family physicians, we see every day in our practices patients who are waiting for specialist appointments, for diagnostic imaging, for surgery, and even to see us. So in the areas of cost, quality, and access, the evidence is clear. We do have much to be proud of, but there is a lot of work to be done. In scanning the policy environment, I see 3 big ideas out there that would truly raise the bar for the health of Canadians in the next decade and help us to address those challenges of cost, quality, and access. I want to be clear that they're not my own ideas, but they are well formulated, based in good evidence, and in my view, they meet those 2 key tests of delivering on the promise of Medicare. They would improve equity of health outcomes, and they are worthy of an iconic program. These are big ideas that have the power to excite people about what it means to be Canadian. Ce matin, je tiens à dédier les 3 grandes idées suivantes à 3 patients canadiens, parce que je crois qu'il est important de nous rappeler pour qui nous faisons ce travail. And so this morning, with gratitude to the innovative thinkers who continue to develop new ways to improve our system, I want to dedicate each of these 3 ideas to 3 Canadian patients, because I think it's important that we remember who we're in this for. So here comes idea number 1, 20 drugs to save a nation, 20 médicaments pour sauver une nation. I'm sad to say that we don't need to look south of the border to find healthcare that's inequitable, costly, and inefficient. An honest assessment of our approach to paying for prescription drugs in Canada reveals a sorry state of affairs. Look, at the time that Medicare was developed in the 1950s and 60s, most healthcare was provided by doctors and in hospitals, and that included medications. So our public healthcare system at that time really did pay for most drugs because medications were mostly provided through hospitals. But today, as you know very well, our healthcare systems are transforming rapidly to meet the needs of an aging population that is living longer with chronic disease. And one of the mainstays of treating chronic disease is prescription medicine. You may not realize that Canada is the only developed country in the world that has universal health insurance that doesn't include prescription medication. And the result is that 1 in 10 Canadians does not fill a prescription or take their medicine as prescribed because they simply can't afford to. Our drug coverage today is managed through a dizzying patchwork of private and public payers working at odds with each other and not in the interests of patients. That patchwork has also meant profound regional inequality. A patient with congestive heart failure might face out-of-pocket costs for prescriptions varying between $74 and $1,300, depending on which province she calls home, or of course, $0 if she's got good private coverage. And it's meant inequity across income levels too. You and I know this because we see patients in our practice every day who can't afford to take the medicines that we're prescribing. So I'm dedicating idea number 1 to a long-standing patient in my own practice who we'll call Ahmed. Ahmed is a taxi driver of South Asian heritage. He lives in downtown Toronto with his wife and 3 beautiful kids, and he works long shifts behind the wheel in spite of his university education and his perfect English. Like so many taxi drivers, his genetic heritage and his sedentary job have predisposed him to his current medical problems of diabetes, hypertension, and dyslipidemia. Although he and his wife are careful in their spending, he simply cannot support his family and pay for his medications. And even if he could afford the deductible for Ontario's catastrophic drug program, he can't figure out how to navigate it. So sometimes I just don't see him for long periods of time. And when that happens, I know that it's because he's not taking his medicine and he doesn't want to disappoint me with his out of control A1C and blood pressure levels. I worry, as I know he does, about the complications he may experience in the coming decades, some of which could be devastating, such as coronary artery disease, visual impairment, and renal failure, all because he can't afford to both feed his family and take his medicine. The most obvious way to fix this problem would be to extend our public drug plans to all Canadians, true national pharmacare, just as we have done for doctors and hospitals. But look, if we can't summon the political will to pay for all prescription medications, let's focus first on those that give us the biggest bang for the buck. Let's choose 20 drugs, or 50, or 100, you pick the number. Drugs that are used to control common chronic diseases like asthma, diabetes, and hypertension. If we can agree nationally to go in on public coverage for these medications, we can cover them for everyone, including Ahmed. And if we did this, we would actually spend less publicly than we currently do. There are 2 reasons for this. First, you may not realize that in Canada we pay much higher prices for drugs than many other healthcare systems, in particular generic medications. If we could negotiate prices like those paid in other developed countries, we could easily cover the cost of 20 drugs to save a nation within our current public budgets. For example, in Ontario, my home province, we currently pay 31 cents a pill for atorvastatin. In New Zealand, the price for the exact same pill is 2.6 cents. The price for 10 milligrams of Ramipril is 19 cents here, compared to a mere 6 cents in the publicly financed Veterans Administration in the US. If we bargained more effectively, the prices we pay even for those drugs we already buy publicly, for example, for all seniors in most provinces, would actually go down quite considerably. Second, other systems achieve these huge savings by bulk buying their prescription drugs on a large scale. Just as we all know it is cheaper to buy your toilet paper in those big packages that have 30 rolls in it than to go to the local pharmacy and buy it 2 rolls at a time, it is similarly less expensive to buy our drugs together than separately. Between our public plans and our private plans, right now we have literally dozens of purchasers of the same medicines in Canada. We would do so much better with just one. We need to make it clear as family physicians to our elected officials that we want to see this issue moved to the top of the priority list. If the family physicians of Canada were to throw our collective weight behind the movement for national pharmacare, or even just 20 drugs to save a nation, I think we could have considerable influence. So reforming our public insurance to include medicines is something that our public officials can do. But as frontline healthcare providers, we need to roll up our sleeves to work on idea number 2, a concept I am calling doing more with less, faire plus avec moins. Doing more with less is about improving access and reducing waits for healthcare by reorganizing the way that services are delivered to people. It isn't a single policy that can be implemented by passing a law. There's no magic button we can press for idea number 2. It represents a shift in our thinking, away from the presumption that the answer to our challenges in healthcare is always more doctors, more tests, more procedures, an approach that has plagued the healthcare system for too long. Instead, we need to start taking the resources available to us and using them more intelligently. This means that when we struggle with access problems or wait times, we don't immediately try to throw money at the problem to train more doctors or buy more scanners. Instead, we would ask 2 thoughtful questions. First, will everyone on the waiting list actually benefit from the procedure or intervention? And second, where is the bottleneck causing the wait? Can we organize care better to improve the flow of patients through the system without spending more? The first question, the question of whether the test or treatment will actually benefit the patient, is one that I know we all struggle with as primary care providers. And to illustrate this principle, I'm going to tell you about a patient who came under the care of a cardiologist colleague of mine who we'll call Sam. Sam was a perfectly healthy man in his 60s. He didn't smoke, he didn't drink, he didn't take any medications, and in fact, he was a world-ranked athlete in a competitive sport. As part of his compensation package at a fancy downtown firm on Bay Street, he went every year for an executive physical at a private clinic. One year, in spite of the fact that he felt perfectly well, he was subjected to an exercise stress test, just in case. Some incidental potential abnormalities were found, and he ended up eventually with an angiogram. Happily, the angiogram confirmed that Sam did not have coronary artery disease, but not before he suffered a stroke on the table, a known complication of the procedure that occurs in 1 in every 1,000 cases. This healthy athlete will never play his sport again because he's paralyzed on one side of his body as a direct result of a completely unnecessary and inappropriate test. Now, when I tell Sam's story to friends and family outside of the medical profession, I watch them struggle with this question, but what if they had found something? And wonder if maybe the risks aren't still worth it to pick up that one undiagnosed cancer or heart condition. But that's exactly the point. We need to stop thinking only about benefits and start talking about harm. As family physicians, I believe we have a huge role to play in that conversation. Friends, millions of Canadians are harmed every year by inappropriate, wasteful, and harmful tests and prescriptions, and many of those are ordered with the stroke of a pen or a keyboard by well-meaning family doctors like us. It is for this reason that, as you know, Canadian physicians, including family physicians, are following the lead of our American colleagues on this and have launched the national campaign Choosing Wisely Canada. As part of this campaign, we're all putting together lists of the top 5 things that physicians and patients should question. Choosing Wisely is one promising initiative, and other groups are beginning to do work on the same theme, such as the terrific Ontario College of Family Physicians Main Pro C program called Don't Just Do Something, Stand There, which is going to be running here tomorrow morning. Mammography for young women, PSA testing for men not at risk, drugs on the beers list for our elderly patients. We need, as a profession, to acknowledge that even good tests and drugs, when used on the wrong people or at the wrong interval, really harm people. And we need to start to wrestle with a culture change that doesn't just lay the responsibility on patients who read something on the internet, but that acknowledges the many complex reasons why we make those little choices every day to tick that box or prescribe that antibiotic. The second question we need to ask when we try to do more with less is whether the bottleneck causing the wait can be alleviated using creative approaches. So what does that entail exactly? We do more with less when we run our practices differently to give our patients the access they need and deserve without sacrificing quality. Nous en faisons plus avec moins lorsque nous exploitons différemment nos pratiques afin de donner aux patients l'accès dont ils ont besoin sans sacrifier la qualité. Today, only 47% of Canadian family physicians report that their patients can get same or next day appointments. But increasing numbers among us are turning to approaches like advanced access scheduling, group visits, phone visits, email visits, and of course, working in teams with other skilled healthcare providers to improve both access and quality of care for our patients. It's important to remember that the innovations we need in our system may not be high-tech and sophisticated, and they may not always involve more. They can be as simple as a single phone number where there used to be many, or as obvious as the better use of Teams so that a surgeon isn't the rate-limiting ingredient in getting access to care. As family doctors, we can each make individual changes in our own practices to help the system do more with less. In fact, each of us could go home and start tomorrow. This brings me to the last big idea, and to a patient in my practice we'll call Leslie. Leslie suffers from severe asthma. She takes multiple puffers. She's been on and off prednisone many times. She's seen multiple specialists, and she's in and out of the emergency department in her local community fairly regularly. Leslie's asthma started when the social housing unit she lives in had a flood. Mold grew inside the walls of the building, and Leslie's health began to deteriorate. She took photos of the mold and brought them to her landlord. Her doctors, including me, wrote letters of support, begging them to find her another unit or another building to move into. It took her and us 2 years to get the system to respond. During that period of time, her physical and mental health deteriorated. She became depressed, her relationship fell apart, she wasn't able to hold down a steady job. She gained weight, and her blood pressure worsened because she couldn't exercise due to her breathing problems. As my colleague Dr. Ryan Miley would say, Leslie isn't sick with asthma. She's sick with poverty. She's sick with a lack of access to appropriate housing, decent food, and the basic human dignity that comes along with being able to make the choices we all want to make to stay healthy. The third idea I want to talk about is a proposal that can be explained without even a passing reference to healthcare. Yet acting on it would do more to improve health than any single other policy we could support. One might call it a dangerous idea. Decades of studies have demonstrated that as important as healthcare is, the social determinants of health, like those that led to Leslie's illness, have a much more powerful impact on the most meaningful outcomes. Low-income Canadians die younger and suffer more illnesses than Canadians with higher incomes, regardless of age, sex, race, and place of residence. No wonder Dr. Gary Block from St. Mike's Hospital often quotes his patient who once told him, "Doc, if you want to make me better, get me some more money." And that is idea number 3, a basic income, le revenu de base, to bring Canadians, all Canadians, up to a decent standard of living. Basic income is a well-developed approach to reducing poverty using the tax system. It's pretty simple, actually. Every year you file your taxes, and if you fall below a certain level, you get topped up to a level sufficient to meet your basic needs. It's an alternative to existing costly and bureaucratic social assistance programs that would virtually eliminate poverty in Canada. As Senator Hugh Segal has pointed out, this is not a radical policy. In 1975 in Ontario, we had a poverty rate amongst seniors of 35%, most of whom were women, and there were stories at that time in the Toronto Star about seniors eating cat food to survive. The Davis government at the time implemented a tax-based seniors income top-up that then spread across the country and formed the basis of our current existing old age security program. In 3 years, the poverty rate amongst seniors went from 35% to 3%. There are very few social policy decisions in our lifetimes that have had this kind of impact. And there's pretty good evidence that a broader population-based basic income policy improves health. In Dauphin, Manitoba in the 1970s, a basic income supplement offered to all eligible residents in a small town reduced hospitalization, particularly for admission related to mental illness, accidents, and injuries. Part of what makes basic income tick isn't simply the money in people's pockets. Income security also means that even those families who never collect a penny know that if they were to fall on hard times, they wouldn't lose everything. And this has positive health effects on the entire community. In fact, basic income is much like Medicare or any other insurance policy. We all pay in, we all hope we won't have to use it, but if we do, there isn't a humiliating process of having to prove our worthiness in order to have our medical bills taken care of or put food on the table for our kids. The same principles that led us to establish universal health insurance underpin the basic income: administrative simplicity, risk pooling, and the belief that access to some basic things should be automatic, a right of citizenship rather than an act of charity. Given that the Manitoba experiment was nearly 40 years ago, it's been suggested by many experts that a series of pilots should take place across the country to figure out how to design such a program for a 21st century Canada. I'm sure every one of you could tell me a story of one of your own patients, like Leslie, someone for whom our medical model can only do so much. I believe that collectively as family doctors, we should do all we can to support a rigorous evaluation of basic income as a health intervention. Let me close today by acknowledging that each of you undoubtedly has strong views about what we should do to improve the health of our communities, and there are hundreds of good ideas where these three came from. But I do think that the test of whether we focus on a particular solution should be the one that I articulated at the outset, namely that solutions should reinforce the value of equity and that they should be worthy of the enormous importance that we place on our most cherished social program. And when we set out to design those solutions, we should do so based on the best available evidence, unapologetically devoting time, energy, and resources to study the effects of our system interventions so that we can learn whether they actually work. As family doctors, we are well used to advocating for our patients. Our relationship with them over time enables us to speak to the complex factors affecting their health, and our role as the patient-centered medical home positions us to advance their interests within the health system. I want to challenge us today to think bigger than that. It is too easy to get caught in the trap of regarding the health system as a fixed reality outside of our control or as something to defend our patients from, rather than engage with for the common good. Ces trois grandes idées nous permettront d'améliorer le système de sorte qu'il fonctionne mieux pour nos patients. En tant que défenseurs de leurs intérêts, il nous incombe de lever nos voix et de réclamer les innovations qui peuvent améliorer les soins de santé pour tout le monde. We have the skills to marshal the evidence and a deep understanding of the human side of healthcare policy. This positions us perfectly to drive system change for the better. So, no more tinkering around the edges. 20 drugs to save a nation, doing more with less, and basic income. If we start moving to do these three things, we will see substantial improvements in the health of Canadians. Canadians like Ahmed, Sam, and Leslie, like you and me. We need to take action worthy of Medicare. Let's go get started. We have a promise to keep. Thank you.
So Danielle, thank you for your keynote address. I think based on some of the things that we've witnessed, it sounds as if it's resonated with all of the individuals in this room. I think that I really appreciate this call to action that you've given us, call to action at the micro, meso, and macro level. And I appreciate the links that you've made to the concept of the patient medical home. You need to know that we're quite active on the files that Danielle has brought to you today, and that is several elements of this are in the report card that the college has produced last year and is continuing to build upon. So I encourage you to sort of get yourself more informed about this if you are interested. And the report card is all about from red to green, from stop to go, and is really a call to action in many of the areas that you've talked about. I now would like to invite Madame Laurence Lévy, Scotiabank District Vice President, Montreal and East District, to come forward for a few remarks to Dr. Martin.
Hello, everyone. I think after listening to what you just mentioned, it's very inspiring. À la Banque Scotia, nous sommes vraiment très, très fiers de s'associer à la family medicine to really make a difference in the life of the patients. Ce qui fait vraiment la différence, c'est que s'impliquer dans la communauté, ça fait vraiment partie de nos valeurs, et de vouloir vraiment se démarquer, à faire vraiment une différence dans les communautés que nous servons. Fait que notre implication auprès du forum, c'est vraiment faire la différence dans nos affaires au quotidien, dans la santé et le bien-être de nos patients. Je pense qu'en santé financière, on parle souvent d'avoir le bon diagnostic. Je pense que c'est assez similaire lorsque nous parlons du diagnostic et de la relation qu'on a avec nos patients. Nous sommes extrêmement fiers and extremely proud to be associated with a family medicine today and to be able to see and share the expertise and the passion of all the people that we have here today. Thank you very much.
Merci, Madame Lévy. And I would like to ask Dr. Ralph Massey to join us for the award presentation to Dr. Martin. And I'd like Dr. Martin to rise and Mrs. Lévy to rise. The CFPC Scotiabank Lectureship Award recognizes an outstanding Canadian or international figure who has contributed significantly to issues related to the health and well-being of people in Canada and or around the world. Dr. Martin, we commend you on your tremendous dedication and passion that guide your outstanding work. Your progressive action and leadership that are making a positive difference to the quality of healthcare of all Canadians. On behalf of Scotiabank, the CFPC and its Research and Education Foundation, it is our pleasure to present you with the 2014 CFPC Scotiabank Lectureship Award. And now it gives me great pleasure to introduce to you the CFPC National Past Presidents joining us on stage today. Les anciens présidents nationaux sont les témoins officiels de l'installation du nouveau président du Collège des médecins de famille du Canada pour 2014-2015, le Dr. Gary Mazowita. Thank you all for being with us today. So I will name each of these individuals, ask them to rise, and ask you to hold your applause until they have all been introduced. Dr. Reg L. Perkin, past president 1981-1982. Dr. Don Butt, 1985-1986. Le Dr. Roch Bernier, 1988-1989. Dr. Brian Hennon, 1989-1990. Dr. Stephen Hart, 1990-1991. Dr. Jamie Boyd, 1991-1992, Dr. Sherry Bethune, 1996-1997, Dr. Nick Busing, 1997-1998, Dr. Dawn Gellhorn, 2000-2001, Dr. Dominique Tessier, 2001-2002, Dr. Peter McKean, 2002-2003, Dr. Rob Waddell, 2003-2004, Dr. Alain Pavillanis, 2004-2005, Dr. Louise Naismith, 2005-2006, Dr. Tom Bailey, 2006-2007, Dr. Ruth Wilson, 2007-2008, Dr. Sarah Credenzer, 2008-2009, Dr. Kathy McLean, 2009-2010, Dr. Rob Boulay, 2010-2011, Dr. Sandy Buckman, 2011-2012, et Dr. Marie-Dominique Beaulieu, 2012-2013. I'll ask the other people we've invited to rise, and I'd ask you to acknowledge this platform party. You're supposed to rise. J'invite maintenant le Dr. Cathy Lawrence, présidente du Collège des médecins de famille du Canada, à prononcer l'allocution sur l'état du collège.
I promised I'd get the right speech out. So, good morning. I have to tell you I'm feeling a little bit giddy. This is kind of a big day and very exciting, and I know that I just wanted to say thank you so very much to Danielle. I thought that was incredibly inspiring, and as I listened to it, it really resonated for me and so many of the things that I've been able to see and reflect on over the last year. So thank you for that inspiration, and I hope we all can individually take up your challenge. I'd like to begin by thanking all of you for one of the best years of my professional life. Being president of the CFPC is no small undertaking, but the load is lessened by the support of staff and the appreciation that I stand before 31,000 members. So much has changed in the last 6 decades since the college was founded. In 1954, the CFPC had 400 registered founding members. In 1996, the first 2 residency programs were established at the University of Calgary and the University of Western Ontario. Interestingly enough, these programs took 3 years to complete, and graduates were then qualified to sit the first certification examination, which was held in 1969 and was attended by 13 candidates. This year, we've increased that number by close to 1,000-fold. In order to meet our mandate, support our members, and continue to be the voice of family medicine in Canada, we underwent a capacity review and reorganized staff to ensure we were effectively meeting our objectives. In addition, our governance review has sought to improve board function and allow for more opportunities for engagement through other meetings. Through the 2012 strategic plan, we are focusing resources to implement a number of activities over 7 thematic areas: continuing comprehensive care, maintaining competence, engaging members, organizational capacity, supporting optimal practice, research, and health policy. Dr. Lemire spoke yesterday in greater depth about the activities that fall under each of these themes. From my view as president, not only can I assure you that a tremendous amount of work is being done to position the CFPC for the future, but also that everything is managed with a prudent eye on finite resources. In 2013, the CFPC conducted a marketing audit with the intent to confirm what is effective and what needs to be changed to support the college in achieving these strategic goals and objectives. What came from that audit offers us encouragement and gives direction in areas that need further attention. 4 of our core programs were seen as relevant by most respondents: continuing professional development, Main Pro, accreditation, and the CCFP designation were all seen as valuable. However, while generally well received, we have some room to grow on other fronts where the CFPC is active. In areas such as government relations, our position papers, national honors and awards, and national media relations, 1/3 of respondents did not feel they knew enough to offer an opinion about the college's activities. We clearly need to do a better job of outreach and external communication to demonstrate that the value of membership extends beyond the college's core services. There were a few other items that I think defined 2014. The work we've been doing to get Main Pro Plus ready for 2015. The goal of this program is to make it more dynamic and interactive, and to stimulate practice improvement through commitment to lifelong learning. The communities of practice committees are evolving and starting to work together. We have seen the benefits of this in some of the sessions here at FMF, where various program committees have come together with their expertise to talk about broader and important issues, and also with the medical marijuana document that was released to all of us in September. On the another front, more medical students are selecting family medicine as their first choice. The 2014 CARMS match indicated that over 37% chose family medicine first. This was a new record for us. Encouraging students to pursue careers in family medicine was one of the most rewarding things that I had the opportunity to do as I traveled across the country this year. And I would encourage you all to share in this work. Talk about your passion, your patience, and your love for what you do every day, because that's truly what helps people understand why this is such a wonderful discipline to be a part of. This past year also saw greater efforts to bring the CFPC and its chapters closer together. The chapter symposium delved into leadership instruction and encouraged chapter leaders to continue to guide the patient's medical home vision across Canada. And in speaking of the patient's medical home, we are delighted that this vision for family practice continues to gain momentum across the country. From municipalities in British Columbia to the provincial governments of Manitoba, Alberta, Quebec, and Newfoundland and Labrador, to partner organizations in Nova Scotia and PMI, the concepts held within the PMH are being embraced as a better model for patient care. One of the highlights of being president of the CFPC is witnessing the impact we make on national policy and the political scene. Over the year, we met with government officials and members of Parliament and the Senate on a variety of issues. And as Francine pointed out, along this line, we are concluding this year with an extension of our campaign focused on the role of the federal government in healthcare. Last year, our report card graded that involvement, and the picture could look a lot better, so we've given them a roadmap. Our Red to Green report helps guide all politicians and decision makers at the federal government level to take two indicators, home care and child and youth health, that were marked as red, meaning no government involvement, to green, meaning full engagement by the federal government. Copies of our Red to Green report are available on the website, and our press conference to launch this report was held on November 12th. So over the year, I've traveled to almost every chapter, and I've been welcomed at their meetings, conferences, and celebrations. Through this, I've been able to better understand some of the issues facing family physicians across this country and how they are finding solutions to address these challenges in their communities. I've met with teachers and educators who are working in large and small communities to ensure our graduates have the competencies they need to serve future patients. I've attended meetings with researchers and seen some of the wonderful work that they are doing to help us better understand our discipline and to advocate for more support at the provincial, national, and international level to achieve this. As part of my travels, I have also had an opportunity to talk to many individual family physicians, urban and rural family physicians, providing a basket of services to their patients in their family practices, as well as those who have chosen or been led by their community to add to or focus their practices on a particular facet of family medicine. What all these conversations highlighted for me was how our context shifts how we use our skills to meet the needs of the population we serve, be it based on geography, a particular clinical focus, or other factors. I've also been able to see the bond that unites us and underlies all of what we do. Our common commitment to the patient and attention to them as a whole person. A generalist approach that allows us to address the undifferentiated problem, accept ambiguity, and manage uncertainty. An appreciation for the patient as part of a family system and a community member that influences them and that they influence. An appreciation for the role that a family, however it is constituted, plays in the health of the patient. And finally, a recognition of the importance of continuity to the long-term health of a patient. Throughout the year, I've had the opportunity to work with a group of incredible, committed individuals who are working to support all of these family physicians. I would like to thank them on your behalf. I consider them not just colleagues, but friends, and I will miss them. In my remarks at FMF last year, and in one of my president's messages, I spoke about tipping the scales for the better of our patients. I imagine it will take the rest of my career to see the full impact of some of what we were doing today on the medical profession and the health of our patients. But I hope that over the last year, the work that I have done on your behalf will help to tip these scales in the right direction. I'm looking forward to taking back what I have learned and all these wonderful ideas shared with me to my practice and my patients, so that I can continue to work to tip the scales at an individual level as well. As I close, I want to say thank you again to my patients and colleagues in Saskatchewan, as well as to my family for donating me to the college for this past year. I hope you know how profoundly grateful I am for having had this opportunity to serve you all. As I step out of this role, I know I am leaving you in very capable hands and look forward to supporting Dr. Mazawida as he takes up the role as president today. Thank you all once again for your support this year, and my best wishes to all of you for the future.
Thank you, Dr. Lawrence. I think I'd like to also acknowledge members of Kathy's family, so her parents and Jess, her daughter, 7 years old, who are in the room. And so, Jess, I want to thank you for lending us your mom for the past year. I know there were some difficult moments as part of this, so, but I assure you that her time was well utilized. And of course, I want to thank Kathy's parents for taking such good care of Jess and enabling Kathy to be able to do her job as president without too much worry. So thank you very much. So now we will be proceeding to the president's installation. Dr. Lawrence?
And now, as my final duty, it is my honor and privilege to officially install my successor, Dr. Gary Mazzuita of Vancouver, British Columbia, as the 2014-2015 president of the College of Family Physicians of Canada. I ask Dr. Mazzuita to rise. Dr. Mazzuita, 1 year ago, you were chosen president-elect, and by virtue of the bylaws, you are about to assume the presidency, the highest office in the College of Family Physicians of Canada. With your agreement to assume this office, do you accept the trust your peers have placed in you to become the leader and main spokesperson for the College of Family Physicians of Canada?
I do.
And Dr. Mazzuita, as our college president, do you agree to commit to carrying out your official duties and upholding the dignity and principles of this office, but serving our college, its chapters, our members, and the specialty of family medicine with professionalism and honor?
I do.
As I pass to you this presidential medal, this symbol of office for the ensuing year, I know you will wear it with pride, honor, and humility. At the close of your term, you will pass it on to your successor as a symbol of progress, loyalty, and devotion to the principles of the College of Family Physicians of Canada.
Mesdames et Messieurs, the 61st President of the College of Family Physicians of Canada, Dr. Gary Mazzuita.
Thank you very much. Yeah. Good. Yeah, I'm okay. Yeah. Yeah. Thank you very much. As my first order of business, it's my very great pleasure to present the past president's pin to Dr. Kathy Lawrence for her tireless efforts and her huge leadership. And on a very personal note, I want to extend my hopes that the Saskatchewan Roughriders win the Grey Cup, Kathy. Oops. Oh, thank you. Thanks, Francine. Thank you. Chers collègues, invités, parents et amis, Jill, Eleanor, Alex, Katie, Magnus, je souhaite remercier très chaleureusement nos excellents hôtes du Québec de leur hospitalité et de réitérer comment c'est agréable de se réunir ici dans cette belle province. Welcome, everyone. We're in a period of change. And really it's a confluence of societal, generational, demographic factors, and it's complicated by political and economic forces. Our own discipline of family medicine is not sheltered from these forces, and our members in our college are impacted. Now more than ever, we must get right our discipline scope and our educational goals. We must revisit and reinvent carefully, but preserve and strengthen wisely. We must be clear what we stand for, who we are, and we must be skilled at what we do. The system imperatives facing us will continue to include the expectations of highly skilled care provision, comprehensiveness, continuity, access, and integration within the broader healthcare system. Quality of care will be an expectation. Our value, which will be defined by our patients and society, must continue to be high. Fortunately, our college is in the enviable position of having members and staff committed to services that Canadians want and need based on values that Canadians hold. We own our educational standards, and we can revisit and refresh them. We can define, design, and validate our CPD requirements. We can test and evaluate through research. We have the ear of government. Importantly, we are unencumbered by self-interest and truly driven by the needs and goals of our patients, both individually and organizationally. The relationships we have built and nurtured with our patients and communities help inform us. A large part of the value we bring as family doctors relates to the notion of family. It's relevant not only to our clinical work, but to our own college. We're a family of colleagues, but the shape of our family, as with all families over time, has evolved. Our family still includes many members who do it all, but increasingly includes members who have focused or part-time or varied practices, members who have gravitated to administration or research, and of course, many members who teach. Within our family, the line between academic family medicine and community-based family physician teaching is increasingly blurred as training sites reach farther afield. Differences in urban and rural practice realities create further pressures that serve to reshape our family. If Canadians are to know what to expect when they see a family doctor and society is to value us, we must pay close attention to understanding, respecting, and reconciling this complex environment and competing demands. This is a formidable challenge. I would submit that success will be dependent on setting our point of equilibrium at our core, which must remain one of excellent clinical care that is comprehensive and continuous and relevant to practice populations and communities. Only then can we expect to deliver to Canadians a high quality and valued basket of integrated services in all communities, regardless of size and location, while at the same time respecting and supporting member interest and scope. The good news is that success will be dependent on our ability to engage in meaningful relationships within and without our college. This is something we're good at, both from the perspective of what motivated us to become family doctors in the first instance and our training. Our newly approved governance changes, MainPro Plus, CCC, PMH, will be important tools in our journey. There are undoubtedly or will be many others. But we more than ever need the collective wisdom of our members. I thank our members for their confidence and the CFPC staff for their tireless commitment to the journey we are on. I look forward to working and meeting with many of you and hearing ideas from all of you. Merci, thank you.
Thank you, Gary. Congratulations, and I look forward to working with you in the year ahead. Before closing this ceremony, I want to remind you about a few things pertaining to today and tomorrow. So a reminder to visit the Open Studio to find out what it's all about and exercise your own creativity. So this promises to be an enlightening and a fun experience. We want you to check the member services area of College Square in the exhibit hall, and college staff will be on hand to answer your many questions. Of course, we have the REF auction, and so you have also some options to bid on some exciting items. And it is still not too late to sign up for the Walk for the Docs tomorrow morning, raising money for medical student scholarship, and you can sign up for this at the REF section of College Square. Last event, convocation, beginning at 5 o'clock tomorrow, Saturday, followed by the FMF celebration at 6:30. We invite you to come and celebrate our anniversary celebration and have a good time. So now this brings our ceremony to a close. I'd like to thank all of our platform party members for being here today. Special thank you to our past presidents for joining us. Always a pleasure to have you all at this ceremony. Je vous remercie de votre participation ce matin et je vous souhaite une excellente journée.